Okay. Welcome to navigating the decision-making of which CSF1 inhibitor to pick for your TGCT. During this webinar, all participants will have their mics and videos muted. There will be a question and answer session where through the chat feature that should be to your bottom right of the screen, you can ask questions and ask to be unmuted or add it on for your camera, and you can feel free to talk to these amazing experts. It just keeps people from talking over each other. We will also allow you guys to ask questions just directly through the chat, and I'll read those. My name is Sydney Stern. I'm the Director of TGCT Programs at TGCT Support. I will be your moderator. We would like to thank our sponsors, EMD Serono, Decipher Pharmaceutical, and Daiichi Sankyo. And thank you all for spending your Friday here. Now I would like to introduce our presenters. That's why we're here, right? Dr. Bill Taps and Richard Reidel. Dr. Taps is a medical oncologist who specializes in the treatment of patients with soft tissue and bone sarcomas. He is the Chief of Sarcoma Medical Oncology Services at Memorial Sloan Kettering. And his research efforts are directly related to the clinical needs of patients. And one of the reasons we invited him is because he is so patient-centric. He has a large clinical practice, and he develops and runs clinical trials that evaluate new anti-cancer drugs and drugs for TGCT. He has a strong focus on laboratory research that strives to better understand the genetic origins of sarcoma. And he has many accolades. I could probably spend the entire time talking about how wonderful both of these doctors are. So I will let them do it justice by actually having a discussion. But thank you so much for being here. And Dr. Reidel is a medical oncologist who focuses also on bone and soft tissue sarcoma. He's a professor of medicine and a member of Duke Cancer Institute and the program director of Hematology and Oncology Fellowship Program at Duke. He partners with each patient so that they know the full set of options available for treatment and can make informed decisions about the approach that is best for them with that information. He also has a large clinical practice and runs clinical trials in cancer and TGCT. So sensing a theme that both of these doctors are incredibly patient-focused, and one of the reasons why we thought it would be wonderful to have them for this discussion that I think is much anticipated with 2 drugs in the market and probably likely more. So I just want to get started into it. Do both of you or Dr. Reidel and then Tap want to give just a rundown of the recent drugs that are available? I don't know if Dr. Tap, you want to take the recent drugs that are available, and then Dr. Reidel of what's in trial, and just give like a brief list of what's going on so people have the same reference.
Sure. Well, thanks, Sydney. It's great to be here talking to everyone, and thank you personally and TGCT support. I think, the big news was we had our second strong CSF1R inhibitor recently approved by the FDA in the United States. So that was with vimseltinib, ROMVIMZA. I'm still getting used to all the new names as well. And of course, we've had Pexidartinib, TURALIO before, and we still have drugs like imatinib and nilotinib, which are good drugs, but what we consider weaker CSF1R inhibitors, and we'll talk about that a little later. But plenty of options now for patients, which is wonderful. And I think Rich will talk a little bit about what's potentially coming.
Yeah, thanks, Bill. And Sydney, thanks for the introduction. Probably the one thing that is unique between Dr. Tapp and I that wasn't mentioned, we actually went to medical school together. We graduated in the same class. So I've known Dr. Tapp for quite some time. It's a pleasure to spend some time with you both. I'll just say briefly, it's an exciting time to be in the TGCT space. Despite being a rare disease, we have a number of therapies that are, well, we have 2 therapies now FDA approved and perhaps more coming. Besides the currently FDA-approved agents that Dr. Tapp mentioned with vimseltinib and Pexidartinib, a therapy that may in fact be on the heels or close to approval is pimicotinib. That's another oral CSF1 receptor inhibitor. It's given once daily, and at least in terms of top-line data that has been reported, we still have yet to see the full data in the phase 3 clinical trial that reportedly met its primary endpoint. So I think there's a lot of enthusiasm in seeing what that actual data shows. There's also a study that's ongoing, the Tangent study, which is looking at emactuzumab, which is an intravenous therapy, a monoclonal antibody that targets the CSF1 receptor. That actually is in clinical trials currently, and I believe has neared or nearly completed accrual. So there's some enthusiasm and excitement about that. We've seen some prior data for that particular drug, which is encouraging as well. There are some other strategies that may be a little bit further behind in clinical development. There are thoughts about looking at injectable therapies directly into the knee, for example. There have been some other intravenous therapies as well, but I would say pimicotinib and emactuzumab are probably the two that are closest behind our existing FDA-approved therapies.
Thank you both. Like absolute pros. And that gets me to the first question is, do you think that there'll be continued interest within this disease, or are we going to saturate out? And Dr. Reidel, you can feel free to go first.
Yeah, I hope there's continued interest, in the disease. Just because we've had some early success with our therapies doesn't mean that we necessarily give up on the disease. Because we can always improve therapies. There are still questions that can be asked and answered, ideally in the context of clinical trials. So while there are a number of emerging therapies, I think it's a good problem to have, if you will. Bill?
Yeah, I would agree, Rich. I mean, I think there's different considerations. You know, Pexidartinib is just approved in the United States, right? So we don't have approved drugs in other parts of the world, with the exception of maybe Hong Kong and a few other countries. So there's a tremendous need to get therapies out to the rest of the world. I also I do think in rare diseases, it becomes challenging as we get more and more drugs to say, how do we create opportunities for patients? But there's still a lot of questions we need to ask with these drugs that we have, like how to properly use them, and what are potentially different settings for people. We have to remember we're not curing people yet. So are there potentially other agents that can come in as we learn about the disease a little bit more, to say, can we cure patients? And I think one of the questions that we'll have to struggle with too is most of these drugs are being approved off of studies that actually use a placebo, right? And there were a lot of reasons why that was done early on. But as we have agents, will there also be different standards in how we design clinical trials and answer different questions, and how that will affect interest and applicability, right? So I think in this business, I'm always surprised, though, whenever we think we're getting drugs, there's always opportunities to do more for people. And so that's why we have to kind of remain vigilant and create this level of advocacy for our patients.
Well, there's no drugs in pediatric patients approved too, right? So
Yeah.
that's a growing area that I think TGCT support is pretty invested in, hoping that someone makes it into that area. But another wonderful example, I think. So getting into more about the drugs, and there's many of them, can you talk or speak to the difference between the mechanisms of even just TURALIO and ROMVIMZA, or Pexidartinib and vimseltinib, and what those differences actually are? And I think some of those differences actually account for the dosing changes and stuff that's been currently done with administration. Dr. Tap, your mic is on. Go for it.
I think in principle, what we know about TGCT is that the majority of the cells that are in a tumor are not the causative cell. Like, in other words, what we would call the neoplastic cell that's causing the tumor. And that's unlike cancers, where the majority of cells in a tumor are the cancer cells. And what happens is the causative cell, that neoplastic cell, secretes a factor into the blood called CSF1. And a lot of our immune cells actually have receptors that, almost like a pheromone, are attracted to the joint because of that CSF1 secretion. So when we talk about CSF1R inhibitors, we're talking about drugs that can actually block the receptor to some degree on the inflammatory cells, so that they don't come to the joint, right? And so what we're actually doing is kind of breaking up that relationship. And that's why Rich and I will talk about CSF1R, which is the receptor inhibitors. And that's a critical process, because we don't know yet if by using these drugs we're actually attacking that neoplastic clone, or if we're just preventing the attraction of those inflammatory cells. And in the past, we've had drugs like imatinib and nilotinib, and these are what we call small molecule inhibitors. So small molecule inhibitors are just drugs that can actually get into a cell, and so they work actually within the inside of a cell. And this is different to some of the drugs that Rich mentioned, which are antibodies, which actually can work on the surface of the cell. But when we thought about nilotinib and imatinib, they are also what we call multi-targeted inhibitors. So they can block CSF1, but it's not their main way of working. So they also block other types of receptors within the cell. So they're what we call weaker inhibitors. What's nice about vimseltinib and pexidartinib is they're much stronger in how they block CSF1, right? So we kind of think of this as the next class of inhibitors. So they're very similar in that regard. They're a little bit different in how they do that. They're both small molecule inhibitors, and I won't get into, how they affect those receptors. In my mind, what the main difference is that vimseltinib is thought to be much more of a specific inhibitor to CSF1R, whereas pexidartinib can block some of those other receptors that I mentioned. And why is that important? I think it's more important from the toxicity profile of the drug, right? So when people take pexidartinib, their hair turns white, their skin can turn lighter, and that's not because of what we're doing with the CSF component, but it's what we're doing with other targets, right? So I think to me that's the biggest differential between the two drugs is what else do they target, and that side effect profile, right? Because that's often going to help dictate how we use the drugs or who we recommend it for. So that was a long explanation of a question. I bet Rich, you could be much more on target.
No, well, I'll just say that I completely agree. I think that the two drugs, vimseltinib and pexidartinib, actually they work very similarly, but to Dr. Tapp's point, one may be more selective or have a more affinity for CSF1 receptor, whereas the other one, at least in the medical field, we will use somewhat of a term, we say dirty kinase, for example, which just refers to the fact that multiple targets can be hit, which can in fact account for the myriad of side effects that we can see. But I think
Promiscuous, right?
promiscuous. In the most basic terms, though, both drugs are highly active against CSF1 receptor.
I always use the analogy of a baseball player. I think probably both of you have heard it, but that TURALIO blocks the ball from actually getting into the mitt versus vimseltinib, which actually tackles the pitcher, so it can't actually it like fully changes the conformation of the so it can't catch it. It's on the ground. And so that's always my attempt at addressing like it's a conformational change. So feel free to use the analogy. Um, I would also like to have you guys specify these drugs have never been put side to side though, right? So we don't know which one works better, even if there's a stronger affinity or stronger binding or more preferential.
That's absolutely right. We teach our trainees all the time that when you're looking at drugs, you should not do what's called cross-trial comparison, which means looking at the results of one trial, looking at the results of another trial, and then trying to infer on that one drug is better than the other. They have not been compared to head. I will tell my patients that both agents have activity, and I think robust activity. And so then we think about other things like dosing schedule and what's important to patients and side effect profiles and patient convenience.
So since we're already on the subject of what matters to patients, when you talk about, we'll just talk about the approved drugs, and then when you start recommending investigational drugs, what do you consider? What are the things that you consider between, we'll just say vimseltinib and pexidartinib, almost as an example, and then investigational? Dr. Reidel, go for it.
Well, I think so there are some clear differences both in terms of dosing and some of the requirements for the particular drugs. Pexidartinib is a twice daily medication, 2 pills twice a day. You have to take it with a low-fat meal. We've had a colleague, Dr. Tapp and I have a colleague who has determined that a low-fat meal is 1 Krispy Kreme donut. You take 2 pills twice a day with a low-fat meal. Based in part on some toxicity, albeit in a small number of patients on the original trial that led to its approval called Enliven, there is a REMS program or a special program that's mandated for prescribers, which really requires frequent liver monitoring, given the potential for hepatotoxicity, and REMS program, twice daily dosing, low-fat meal. I think those are the things for Pexidartinib. Vimseltinib is twice weekly. It does not have a REMS program. There was some changes in the liver function test seen on the study. And so there is recommended liver monitoring, not mandated, for vimseltinib as well. But in my mind, those are sort of the sort of differences between some of the two, independent of the side effect profile.
In vimseltinib, it was kind of because of a class-based effect, right? Like the impact of pexidartinib had a ripple effect for other drugs in that class, and that's why
Correct.
vimseltinib, right?
Correct. And I actually give the sponsor credit, to be quite honest, because while there was not sort of severe hepatotoxicity seen in the study that led to approval of vimseltinib called MOTION, I think there was a recognition of just doing due diligence, and because of a potential class effect, meaning a potential side effect related to any medicine that targets the CSF1 receptor, they just recommended due diligence. So I appreciate that and respect that.
So Dr. Tapp, when we talk about class-based effects, what are some of the side effects shared across the entire class?
Well, I think we have to look specifically at what happens when we target CSF1, and now theoretically, vimseltinib, which is a more specific CSF1R inhibitor, should give us some keys to that, right? And I think some of the side effects that we saw with vimseltinib were that patients could get some facial swelling or some general swelling, what we call edema, which I thought was interesting. You know, we always attributed that to a different target of the drug, but that definitely seems to be a part of it. We also saw some people getting a rash, which is always hard to say if that's related to CSF1 or maybe something within the drug. And we actually saw people getting some slight hypertension, right? So that's another thing as to why a CSF1 inhibitor could cause some high blood pressure, and it may be related to just some of the fluid shifts in the body. We can also see some effect in the liver cells, what we call the Kupffer cells, and because of that, we can see elevations in some of the liver tests, and most of that is, excuse me, very reversible and modifiable, but it's probably where the drug is cleared. There's some thought that we can see some effect on the glial cells, which are cells within the brain. And so we also look for some short-term memory issues. And then we can see some issues with enzyme clearances. So there's an enzyme called CPK, which is thought to be a muscle marker, which we can just see that rise, but we don't think it has a clinical thing. And I'm going to take a sip of water and let Rich take over here.
No, I think so. Bill is absolutely right. The elevation in the enzyme is related to a clearance. Historically, when we see those sort of findings, we get worried about muscle injury. It's important to note that is not the case in these drugs. And so you can see an elevation, but it's really of no clinical consequence. Dr. Tapp.
When you're talking to patients, so we've seen patients, they get the rash, they get itching, sometimes with or without a rash. They may get some photosensitivity. Those are kind of the big ones. We see fatigue, the concept of chemo brain, which is poorly measured, and maybe no one puts an exact number of how many patients are actually affected by it. So do you, I guess both of you, think that that's regarding the actual mechanism or blocking of the CSF1, and that may happen with all the drugs, or maybe more in some and some versus how promiscuous the drug is?
Yeah, I think the latter. I think it's going to depend on perhaps the affinity to the target. And it just speaks to the fact that these drugs, while in the same class, are very different drugs. And so we can see a differential side effect profile for each of these.
In the hair color change, Dr. Tapp, that's just Pexi, imatinib may cause, differences a little bit in hair. But why is that such a hallmark side effect of Pexidartinib?
I think Pexidartinib is also a strong inhibitor of a gene called KIT. And KIT, we often see mutated in other cancers. One of them is a cancer called GIST that we also treat. But the KIT gene in its wild type form, meaning its general form, is important for the production of melanin and melanocytes. So it's interesting that there's actually a disease in which people are born without that gene and they get hypopigmentation, and it's a gene that's called piebaldism, and it's a fascinating or disease called piebaldism, named after the magpie and the bald eagle, right? Because they also have whiteness within their feathers. So that's, I think, why it's happening. But it's not with TURALIO or Pexidartinib. It's not only the lightening of hair, but it's also the lightening of skin. So that's really important because that can also cause issues with sun exposure. And for people who have darker complexions, that lightening of skin can also be sometimes very challenging, right? So you have to just explain the toxicities. They're reversible, but while you're on the drug, you'll be experiencing that.
So we're getting some good questions in the chat, so I'm going to shift a little bit. One patient asked, why do we use these medications mostly to treat recurrent or diffuse disease? And is there a role for them in localized disease? And I think Dr. Tapp and I have maybe this conversation frequently. So I'll start with Dr. Tapp and then switch over to Dr. Reidel.
Yeah, I first of all, I think the nomenclature we used of localized disease is challenging because almost all TGCT is localized and localized to one joint. It's just that when we use the word localized for a form of the TGCT, what we often, I think, is better described as nodular, right? Which really just represents a really small nodule in the joint that's encapsulated and very focal. 99% of the time, that's cured with surgery alone, right? When we think about these medicines, we think about more of the diffuse disease that is still contained within a joint, but it can be very diffuse throughout the joint. So it doesn't necessarily just look like a tumor. And for that reason, it can be very hard to resect or remove by surgery alone. And often a lot of disease is left behind. And some of the surgeons, that I've spoken to said, operating on a diffuse type of TGCT is almost like operating in mud where you're trying to pull out all the different aspects of it, but, you just can't get anything. So that's why we often talk about using the medications in the diffuse type, right? Because surgery is often not curative for patients. I will say, because these medicines have side effects and because it's difficult to be on medications, one of the ironies from our side is we spend all of this time trying to get drugs approved for patients, but really once we have them, the goal is to figure out how not to use them, right? So, one of the first discussions that you should have with your physicians is, do you need the drug and what is the goal of therapy? Because all of these drugs can have side effects or lifestyle changes. They definitely can be helpful, but you have to really consider when it's right for you, right? So that's important.
This risk-benefit assessment per se, that the side effects can't be worse than the disease itself, right? So
Well, but that's right. And it's interesting because our experience, at least my experience with the drugs, is when we first started developing trials for it, people didn't have drugs. So, they really were having a lot of issues with the disease in their joint. But after a period of time on drug and you have resolution of those symptoms and improvement in quality of life, actually taking the drug was what became most difficult for people, right? Because it's like, I'm tired of coming in, I'm tired of having fatigue, I'm tired, because that became, the quality of life issue more than the disease itself, right? So there is this fine balance in how to do this correctly. And I think because TGCT is such a variable disease, you have to develop that relationship with your oncologist to figure out, when and how to use the drug.
And I will say that there's exceptions to every rule. Gotta love the exceptions in medicine and science. And so we do have patients with cervical spine that is technically a localized tumor that is not surgically amenable. So there's always considerations that are worth the disclaimer. Talk to your physician or your team about those specifically. So Dr. Reidel, how soon do patients that you have, how soon do they notice that the drugs are working, and how is that in relation to side effects? So if we're talking about timelines.
Yeah, so I think, at least in my experience, for patients in whom we consider the drug, they typically have a significant symptom burden. To Dr. Tapp's point, a number of patients that I see that are referred, I actually encourage continued observation, in part because their symptom burden is not rate limiting for them. They're still able to perform their activities of daily living. They may have some discomfort or some functional limited functional limitations. But for those who were considering drug, it's actually quite impressive and marked in terms of improvement in their symptoms after starting the drug. It could be, in my experience, within a couple of weeks, and certainly within a couple of months for sure, where they have significant decrease in swelling, improvement in pain, improved range of motion. They can do things that they weren't able to do. It's quite striking, and I think in my clinical experience mirrors what was seen in the clinical trials with the improvement in a variety of patient-reported outcomes, which to me are just as important, if not more important, than the actual shrinkage that's reported on some of the more objective measures. Toxicity, at least the hepato or liver toxicity that can be seen with Pexidartinib. Typically, if it's going to happen, it happens early, which is why the monitoring is weekly for the first 8 weeks, in my experience. And I certainly have seen individuals who develop elevation in their liver function test to suggest some perhaps developing injury. We hold the drug, it improves, and you consider a dose reduction. So for me, side effects, the whitening of the hair will happen within the first couple of weeks as well. So side effects can happen early, but symptomatic improvement can also happen early.
And just to clarify that ROMVIMZA or the trial-associated motion for vimseltinib did not see any hepatotoxicity, but ALTs and ASTs, or these liver function tests, did elevate, but they weren't to the same extent, correct?
Yes, I will just walk back the term. I do think there is the potential hepatotoxicity by virtue of the elevation of the AST and ALT, but not the what we call cholestatic picture where there was severe changes.
And what's important is ALT and ASTs and these liver enzymes are transient, right? They go back and forth, and that's why we monitor them until a certain point, and then you're like, oh no. But there's the analogy of the stoplight. There's green, which we're good, and then monitoring, which yellow, and then where you have to go off to reduce some of those. And so people were in maybe the yellow, right, for ROMVIMZA, but no one got to the essentially the red, in which it was like irreversible toxicity that was seen.
Correct.
Okay, just to clarify. Um, Moving on to some other questions. So now we have 2 drugs. How are you consulting your patients? So we don't know which one works better. So how are you consulting patients on making those decisions? And for people listening, there's no wrong or right answer to this. So I'm not setting them up, but just because they have those thoughtful discussions, they're the right ones to ask. So Dr. Reidel and then Dr. Tap.
Yeah, I mean, it's a good thing. It's a good problem to have that we have 2 agents. And so I think you have to, as a provider, I try to have an informed conversation with my patient about the pros and cons of each agent. The pros in my mind for Pexidartinib include the fact that it's been around since 2019. Is when it was FDA approved. We have experience. We know how it works. There's a well identified toxicity profile. We know how to sort of manage that. The downsides for Pexidartinib, in my opinion, are the potential pill burden. So 2 pills twice a day. There's a food restriction, a low-fat meal each time. From a provider standpoint, there's participation in the REMS program, which is relatively a minor inconvenience, but may limit providers' willingness to enroll in that just because there is an administrative burden associated with that. Vimseltinib does not have the REMS program. It is twice weekly. Now, that may be seen as a pro or a con. It's a pro in terms of decreasing pill burden. It may be a con in terms of individuals remembering to take the medicine. I'll tell patients take it on Monday and Friday, for example. That may be easier than Tuesday, Saturday, Wednesday, Sunday, something like that. Then it's also a reflection of the pros and cons regarding side effects. Whitening of the hair versus no whitening of the hair, Pexi versus vimseltinib. Periorbital edema, more with Pexidartinib. I'm sorry, more with vimseltinib than Pexidartinib. If someone has uncontrolled hypertension, we have to think about hypertension with vimseltinib. And so it really is individualized and requires a thoughtful conversation so patients can make an informed decision. Bill?
Yeah, Rich, I mean, I think you set that up perfectly. The only other thing I'll add, which we don't know about yet, is cost, right? Because these are pills, it often is a copay associated, and we don't yet know what that is for everybody or if it will differentiate. We also don't know if providers will say which drug we can use or not use, right? So that's really unanswered questions. The one thing that I'll say is that, you know, we have a luxury in TGCT because it's not a cancer that we can really try to individualize approach for patients. And it's very hard to predict, although we know a lot about the drugs, how each drug will do for any given person, right? So it's really important that we try some of these medications when they're needed, but really can adjust and dose and base it off of the things that are important in someone's life. So I think Rich mentioned that the luxury is having different options, you know, and again, because these are not curative, people may need drugs at different points in their life and may have differential experience with some of the drugs too, right? So that becomes really important in understanding which drug we can work with in the best way for an individual to make sure that we're helping with their symptoms and that we're not causing any issues with quality of life, right? And I think having two drugs is very important for that. And I'm always amazed at, you know, we have preconceived notions of what will happen with a drug, and then we see something totally different, right? So I would just, for people out there, have an open mind and really work with your doc to figure out which drug is right for you, how to use it in a way that's right for you. And there's still so many questions that we don't know the answer to. Is what's the right dose? Do we need a dose to start with and then a lower dose to maintain? How long do we use these drugs? And I think because the disease is so variable, right? We can't just come up with global conclusions, but have to work closely with you. And I've always found that my patients have taught me more about how to use these drugs than any study we've been involved in, right? The studies give us guidelines, but, you know, please work with your docs to help them understand how to use the drug for you. And what I've also found is over time, my patients kind of tell me how they're going to use the drug, which I think is wonderful.
I think people can feel what works, right? I think there's prescribed labeling, which is obviously a recommended framework, and then there's clinical judgment, which means, Dr. Tapp, we have or you have a wonderful patient that I know well that's on the 125 every other day, right? That's not within the prescribed dosing, but it works for her. And so one of the
That's right.
reasons we appreciate both of you is how focused you are on finding what works for the individual, which may not always be so within the trial, right? Trials are populations, not individuals. So we both all appreciate that effort. Also, with some considerations for these drugs, approved drugs, I know trials are much stricter, but how do you discuss fertility concerns or concerns related to childbearing women, since this does affect mostly younger individuals who are potentially childbearing age?
I'll go ahead and start. I send all of my women of childbearing potential to our fertility clinic to talk about fertility preservation measures. To Dr. Tapp's point, we don't know what the optimal duration of these therapies are. I think many of us in clinical practice will treat to a maximum response and or improvement in symptoms and then consider taking a treatment break. I fully recognize that that is not the way that these were studied. But if there is the potential for effects on fertility that can be longer lasting, we'd hate to miss an opportunity to address that up front with preservation measures. So I will refer all my patients early prior to starting therapy.
Yeah, I think I agree with that. And I think it's one of the more challenging things that people are confronted with because we know there's a slight preponderance of TGCT in women, and it often happens at a younger age. So it's a real important question. And I think there's two components to it. One is the fertility issue. Do these drugs affect long-term fertility? And hopefully that won't be the case, but we don't have data to say that. And the other is, will it affect developing baby in utero, right? So it's really important that when you commit to a drug that you don't get pregnant while on therapy, right? Because we just don't know if that would have an effect. Drugs like imatinib, we actually are getting some long-term data about how safe it is during pregnancy, but we don't have that yet. So I'm the same way where I want all of my patients to undergo fertility counseling. And we would even say if people are planning pregnancies that they wouldn't be on the drug within 6 months of a pregnancy. So often the question is, could we start this drug, use it for a sufficient enough a time to control the symptoms, and then stop it where we have, X number of months off pregnancy where we would be able to, conceive safely, right? So those are some really important questions. And again, it goes down to how bad the symptoms are. What is the family planning situation, right? And so these are all really important questions to struggle with before you start a drug. But again, because this is not a cancer, you can always err on the side of being a little bit more cautious, right? And that's what's really important.
And vimseltinib was wonderful enough to put in the label 3 months is their recommendation for cessation before attempting to have a successful pregnancy. So it was nice to see someone parameterize it a little bit. I hear 3 months, 6 months, right? Everybody has their own clinical judgment, but to see some form of regulatory judgment was nice to see as well. Um, moving on as with considerations, we know that Pexidartinib wasn't approved outside the United States. And vimseltinib may, it looks like it's likely on that path, but can you speak to why Pexidartinib was not approved in, say, Canada or Europe, and why vimseltinib will likely be approved, which we don't know about cost, and both of you are not in regulation, so there's no under disclaimer that says that anything that they say about it being approved is actually going to happen. So there's your safety net for you guys. But Dr. Tap.
Yeah, it's a complicated question, right? I think part of it goes down to how complicated the phase 3 study was that led to the approval of Pexidartinib. First of all, older technology was used in gathering some of the patient-reported questions. It was a very, very labor-intensive study for patients, right? It did set the paradigm of how all of the other studies, have been run, but because of that, there was a lot of missing data. We required patients to do a lot of homework, and people don't always want to do homework, and we totally understand that. And then because of the technology, there was a lot of missing data. When you have missing data in a clinical trial, regulatory bodies can question the overall conduct of a study, right? So that came into it. I do believe there was a question of how bad is this disease for people and how meaningful the outcomes were for people. Now, that's not something that we would question as clinicians who treat the disease, nor would we question with patients. But it was a big question with regulatory bodies where they just didn't know if this was a disease that needed a drug approval, and this was the right drug based on the results, right? So there was a lot of controversy with that as well. So unfortunately, we didn't see the approval of Pexidartinib, which is a shame. The flip side, we hope vimseltinib will be improved. It has allowed over the years since Pexi was approved in 2019 to really set up informational campaigns to explain how important this is and how important the drugs are. So we have that benefit. We have the benefit of what's happened in the United States with Pexidartinib. So we're hopeful for vimseltinib, but still, there's a lot of considerations that go into looking at data sets from regulatory bodies. So again, just a kind of blanket thought, but the details are, really important, and regulatory bodies really go through those details to try to do the right thing for people.
I think it's important to note that not only the educational campaign, but patients talking about it more and different resources. I like to believe advocacy resources have been promoted and changed that. But until recently, the EMA in parts of Europe did not require patient-reported outcomes. And I think maybe vimseltinib benefited from the fact that they saw patient-reported outcomes that were useful for the Enliven trial and maybe move those up into secondary endpoints. And I think that was able to show, or at least in the United States, able to show potentially how successful it is in a meaningful way to patients, like that your function. So, and I'll probably ask Dr. Reidel that disease shrinkage isn't always correlated to symptom benefit and vice versa, right? Patients have benefit without substantial shrinkage in their disease. Can you speak to how you consult or consider patients? Do those patients stay on the drug, and how those decision makings happen?
Yeah, I alluded to this perhaps a little bit earlier when I was saying that, at least for me, symptom control and symptom management to me is more important than an objective response in terms of shrinkage of the tumor. And you're absolutely right. We can see symptomatic improvement without significant change radiographically with MRI imaging, for example, and vice versa. So for me, I will either treat. For me, I will consider cessation of treatment when maximum symptom improvement has been achieved. And it's not necessarily maximum shrinkage. So as long as they're improving symptomatically, regardless of what the imaging shows, I will consider continuing the drug, because I think the symptom outcomes are more important.
Dr. Tapp, I know your answer, but dazzle us with your similarity.
Yeah, I mean, it's totally similar. I mean, I'll sit down with people and really ask them like why they want to start it and, what is the quality of life that the disease has caused that we can see a change in. Now, TGCT is difficult because people can have, say, pain in the joint for a lot of different reasons, right? There's definitely tumor pain, but in people who've had multiple surgeries or some destruction of the joint, they can have arthritis. And most people can actually distinguish different types of pain. Like they'll say, oh, this is my arthritic pain and this is my TGCT pain, right? So it's often complicated to understand what we're trying to help with. But clearly, a drug is not going to help with arthritic pain, but it could definitely help with tumor pain. But most people will say very practical things. Like I had one patient who said, "Yeah, I'd love to go to concerts, but I can't stand for more than 2 hours. So I'd love to be able to stand or walk up a flight of stairs or get out of a chair." And these are the things that are most important when we start a drug, to be able to say, are we helping in that regard? I agree that tumor shrinkage is not nearly as important. And it's actually the diffuse type is very, very hard to image correctly on scan. So when we think about tumor shrinkage, especially on the clinical trials, it's really just an artificial measurement of what's going on, right? So that's why symptoms are really important. The other caveat, at least with tumor size, comes down to protection of a joint. And that becomes important because of this inflammatory nature. You get that inflammation can destroy components of a joint over time. So it's why Rich and I will work very, very closely with the orthopedic oncologists who know this disease before we start a drug or when we start a drug, because if they can tell us how that joint is doing or whether or not the joint is at risk, that also brings a component into what we're trying to do.
Bill, I'll
So
just follow
some,
up. That's a great point, because we will often discuss cases in the setting of a multidisciplinary tumor board. We will look at the imaging, we will discuss the patient's symptoms. And while the patient may have recurrent disease after a prior surgery, the burden of disease may not account for the symptoms that they're having. And to your point, it may, a joint replacement may be more appropriate to manage the pain, as opposed to starting them on a systemic therapy that, to your point, will not have a meaningful impact on their symptoms.
but saying that replacements are not curative, right? So they may end up on a drug anyway down the line, but just not yet. I think that's commonly, thankfully, with a lot of education, that's shifted a little bit. But the discussion of when to do surgery and what type of surgery and that replacements aren't curative is a great one to have in these multidisciplinary settings, right?
And
Or
I will say that drugs don't replace surgery, right? So for some people, surgery is a better option than a drug, right? Because you can go through a surgery, maybe remove a good amount of the tumor, and you may have post-operative recovery, but then often can go for long periods of time without symptoms. And you can weigh that with starting a drug and shrinking a disease, but then being on a drug for a year or longer, right? So it's really having that multidisciplinary discussion, and that includes the medical oncologist, it includes the orthopedic oncologist, and it definitely includes the patient, right? Because ultimately we have to figure out what's important for you and what's the right options for you. But we have to put all those options on the table so that the right decision is made.
Yeah, we appreciate. I think all of us in this area either have had one surgery or multiple, and so being on that surgery cycle, just having another option, or even being told, hey, it's unlikely that surgery will remove it all. Would you consider another option if macroscopic resection is actually truly the end goal? So it's a great plug for multidisciplinary centers like Duke, like MSK, and like others on the TGCT specialist list.
But I will say, Sydney, now that we have drugs, we're trying to learn the approach, right? And there's early data to suggest that if you use a drug before surgery, maybe you have more symptom improvement than if you would have had a surgery. This is really early data. So if we can understand something about the sequencing of therapies or when we use our therapies, that's important. So that's a plug to you and the TGCT support of the registry and also gathering that information because we need to learn from every person who's going through this, both with surgery, watch and wait, and drugs, so we can then understand like what's right or what are the trends that we really need to follow up on.
It's a great point, Bill, because there are a lot of questions that, to be quite honest, probably may not be answered or will not be answered in the context of clinical trials. So we rely very heavily then on this emerging concept of real world evidence. So we take the experiences within the community, within the patient population outside of a clinical trial, and that can still inform our decision making. So I completely agree.
So just a plug for people filling out our registry and participating, which is over 1,500 people now. So it's growing, and both Dr. Bill Tapp actually just recently presented it at a conference. So hoping to continue for us to do our part and make sure that these wonderful providers have the ability to make considerations that are truly patient driven, which would be directly from patients themselves. So thank you for the plug also. So as we start talking about more how to give these drugs and what's the best way, when do you consult patients on going on a break once they're already on? Is it purely based off side effects, or is it driven by a stagnant course in their disease, or what are the considerations? Dr. Reidel and then Dr. Tapp.
I think it's all the above. It's tolerability to the drug, and how much of a burden the day-to-day side effects are for a patient. You can imagine if someone has a little bit of nausea or a little bit of diarrhea on a daily basis, that can still be impactful to that individual. Certainly, as we've mentioned a couple of times, the symptom burden and the improvement, of symptoms is critical. Radiographic changes are part of that, process as well. But for me, it's a balance between symptoms and toxicity. And so if I see that we have maximized symptomatic improvement, and if there is some concurrent side effect on a daily basis that is a bit of a drag, fatigue, nausea, diarrhea, for example, periorbital edema, then we can have that conversation about taking a break. We do have some early data that if you take a break, you can reestablish disease control with resumption of therapy. We've seen that in some other diseases that Dr. Tapp and I treat. So that at least provides, for me, a level of comfort in taking a break for what otherwise is going to be a non-life-threatening condition.
I would agree wholeheartedly with that. I think, clearly in the beginning, it's establishing the right dose and really treating to maximal response. We also know from the studies that we can see kind of improvement over time in some people, right? So there are some people that still get improvements over time, but I think most people really do improve fairly quickly. And then the drug is being used to maintain the disease. And probably in a maintenance phase, there's a lot more flexibility in what you can do. And what I found is patients really begin to understand that. So they know some of the toxicities and say, I'm doing well, but fatigue's building up, so I'm going to take a week off. I'm going to take 2 weeks off. People will say, I'm doing great, but I have a wedding coming up, or I'm going on vacation, so I'm going to stop the drug for a few weeks. So again, we're fortunate in that we can allow for a lot of flexibility in this, and patients really understand how to best use the drug for them. We don't know how long to use the drug. I tend to use it for about a year and then stop. What I've found, and again, this is just personal experience, is that some of the tumors in smaller joints, like the elbow, actually can remain stable for long periods of time. If tumors were bigger or more aggressive, like in the knee or hip, we can see the tumors start to grow again after being off drug. But it's very variable for people. Some people go for years, some people, we could see it within a year. But we have to remember that just because you see a little growth doesn't mean that you need to be back on drug, right? It's often based on when symptoms would develop, right? So understanding the longitudinal effect of the drug and what happens when you stop the drug becomes very important in understanding how to treat people. So a lot of patients will lower doses over time. Patients will decide differently when they want to stop, but how we follow up and when we would restart drug is also an important question.
Thank you both. So similarly then, do you ever start at a lower dose and titrate up? I know the approved dosing is always right. You start at, depending on the drug, the highest dose, and you modify based off side effects. Do you ever start at a lower dose and modify up? I know Dr. Tap can start because I was Tap's patient, so I know the answer to this, but still.
Yeah, and Rich and I may disagree a little bit on this, but I am, totally fine with starting at a lower dose. What I think is important early on is consistency. And sometimes when you start at a lower dose, it allows people to acclimate better to the drug, and oftentimes we can get a very nice response at a lower dose. And that's the dose that we would actually use, and there would be no need to escalate the dose. In Pexi, that could also affect the food effect, right? Because if you're on a lower dose, you don't need to be as rigorous as your diet. The downside to doing that, and I hope Rich will talk about this a little bit, is we know most of our parameters, especially early on with the drugs, with using the FDA recommended dose. So there's also questions that if we change that a little bit, does that affect the monitoring or when we can see liver toxicity, right? So there's that discussion that needs to be had, and I'll let Rich talk a little bit about that if that's what he's going to talk.
Well, I think Dr. Tapp nicely sort of articulated the pros and cons. I will just say, as a corollary, in other disease states where I'm using small molecule inhibitors, I do historically, from experience, I will start at a lower dose and titrate up for the reasons that Dr. Tapp mentioned. In TGCT, out of full disclosure, I find that most patients tolerate full dose, and so I will start at full dose. I'm a bit of a purist, and I will do what the trial did. I'll start at full dose, and then I will dose reduce based on toxicity if needed. I do worry a little bit about if someone starts at a lower dose and titrates up. The liver monitoring is weekly for 8 weeks. And so at that 8-week mark, someone may have only been on full dose if they do titrate up to full dose, a shorter period of time than if you start from the very beginning. And so do you then extend with continued weekly monitoring? I worry that at least for Pexidartinib, that there may be the potential for missing hepatotoxicity by starting low and then titrating up over time and basically prolonging the time to get to full dose. But I fully recognize Dr. Tapp's point that some patients can get by with just a lower dose, and if that's the case, great. So I think there'll be different opinions and practices. It's part of the art of medicine.
It is truly art.
Yeah, and Sydney, I think, this is where patients have agency, right? Because, both Rich and I, although we have kind of our guidelines, there's no hard, fast rules, right? So it's understanding what's the goals of care, what's the disease doing to someone, and patient preference, right, is also really important. It's just how we could create this level of discussion and information to help make the right choice.
I think it's also helpful that while we're discussing as if there isn't third parties involved, but insurance companies, and to Dr. Reidel's point that you may not get approval for additional liver-based testing or blood testing on a weekly basis after the 8 weeks. So there's other players involved that very quietly make most of our decisions, I feel like, outside of the room to consider as well. But another discussion to have with your prospective team, and hoping to find someone that is going to care and consider what the patient wants is obviously of the utmost importance, as well as the expertise that they have. So both of these amazing providers have an abundance of both anecdotal experience, but also scientific experience, which I think is why you guys are as elite as you are. But is there any advice that you could also give patients who are navigating and advocating for themselves on if their provider isn't as eager to maybe listen to their considerations or have those discussions, what your advice would be? And Dr. Reidel, go ahead first.
I tell patients all the time that they're their own best advocate. And I'd like to think that most physician providers or medical providers are willing to partner with patients and do what's in their best interest. Um, I always encourage patients to consider second opinions. I'd like to think that most medical providers will not be offended by that, because in the end, we're working towards the best interests of the patient. I tell folks all the time, I'm happy to partner with community-based providers. These drugs are new. There is nuance to how they can work and the management of the toxicity profiles, and we're happy to partner with community-based providers, uh, you know, uh, on that. But I think patients are on the line. You've already found TGCT support, so I think that's fantastic. So whether it's through your medical provider, self-education, working through patient advocacy groups, which are wonderful partners with academic centers, I think there are a growing number of options to both for education and advocacy, and I would encourage all of you to seek those out, as you've obviously done and being here today.
Yeah, I think Rich said that beautifully. I mean, I don't have more to add. With the exception to realize that, Rich and I spend a lot of time thinking about this because we see a lot of TGCT patients. Most oncology providers or practice providers don't. So they may not be as familiar with the disease or the drug. And so having information that you can discuss with them, I think is really important. But I also think it's important why, even if you have a few time visits with someone who specializes in TGCT, it allows for you to have a more comprehensive care team around you. And as Rich was saying, that doesn't mean you need to travel to centers to get day in and day out care, but at least you have people a little bit more familiar with disease and drug that can help guide when there are tougher questions or questions in general. But all of us want to work with local physicians to really say, how do we best care for you, right? That's the goal. We are all here to be part of your team, and creating that team that works for you is the most important thing.
You guys say it so much better. I always say that you want someone to write the recipe that knows the ingredients, but anyone can follow the recipe after that. So I'm like, start with someone who can write the recipe and then take it to whatever community, especially in maybe medical oncology where they're literally following a recipe. But have you guys write it. So that's always, I love my analogies for random things. And so we did have a last question. I want to be mindful of your time. So patients who do have toxicity on TURALIO, for example, would they be able to go on ROMVIMZA or vimseltinib as an option, or are these toxicities similar? We can use the hepatotoxicity as an example, and then maybe general toxicity like grade 2 rash, like just someone who's completely rashed out from one of these drugs, can they switch without having the same issues? And Dr. Tapp and then Dr. Reidel.
Yeah, I would think so. It's not only a side effect, but also an efficacy. Like one drug may work slightly better for someone, but generally, we don't necessarily expect that you'll have the same toxicity to the drug. Now, sometimes there can be a class effect, but that's rarer. In working with these drugs all the time, generally, different drugs have different toxicities. I will say, there's still some question about people who've really had a bad case of that cholestatic liver toxicity. We do think that vimseltinib will be a safe drug for them, but whenever you've experienced significant liver injury and all these drugs are cleared in the liver, you have to be very, very careful, right? So if that's happened to you and you're thinking of starting vimseltinib, I would still recommend having a liver doctor or hepatologist following and being really, really careful with blood draws and monitoring.
I'll just briefly say that sort of situation, if there's overlapping toxicity between the two drugs, and I'm going to switch because of lack of tolerability for the first drug, I certainly would start at the lowest dose for the subsequent drug. So that is a situation in which I would not start at full dose, particularly if the toxicities are potentially overlapping. But that in and of itself, it wouldn't preclude me from considering the second or an alternative agent.
Thank you both so much for your time, and we didn't even get through half the questions, so we will definitely have encore presentations of these, but I appreciate your time very much. And for those as well for spending your time, thank you. And we will have another webinar May 5th for Cinco de Mayo, and that'll be going through our registry data that was just published. So grab a Cinco de Drinko and come hear more about research. Thank you both very much, and we appreciate you very much.
Thank you.
Thanks,
Thanks.
everyone.
Bye, guys.